Yes.
Yeah, great. What I'd like to cover today, is a basic overview of eye injuries. So you've got an idea of what sort of things happen to an eye, and a basic understanding of what sort of things we do to manage that, which actually often is surgical, but a bit of where medication fits in. And so then where different medications fit in terms of systemic and topical treatments. So the first thing to cover is the basic and ocular anatomy. So you've got an idea of what different injuries will do to different parts of the eye. So apologies if you're very familiar with this, but essentially we've got front of the eye, which is the cornea, the kind of clear bit that covers the eye. Then you've got the coloured part of the eye, which is the iris, and the pupil in the middle, which is the hole in the middle, the lens behind, and then the back of the eye is covered by retina. And inside the eye, you've got vitreous for most of the eye, and inside the front of the eye, you've got aqueous. And when we see patients with eye injuries, we want to conduct often quite basic examinations, and it makes patients particularly stressed and uncomfortable. So the first thing we want to be able to do is to deliver anaesthetic. And actually, we can usually do this quite effectively just with topical preservative-free anaesthetic, or delivering or analgesia systemically. And that helps us examine the eye and helps the patient to show us what level of visual function they've got. So different types of eye injury. Well, eye injuries are divided into open globe injuries and closed globe injuries. So open globe injuries are injuries where there's a hole in the eye. Closed globe injuries are injuries where there's not a hole in the eye. So that's whether the eye wall is breached or not. Closed globe injuries, there can be a cut that doesn't go all the way through the eye wall, or there can be a contusion, which is a whole range of different injuries that I'll cover later. And then not covered in this are burn injuries, which I'll also cover later. In open globe injuries, you can get ruptures where the eye's been hit so hard it bursts, and then lacerations where there's essentially something relatively sharp that's made a hole in the eye. If it's gone inside the eye, it's penetrating. If it's gone through the eye, it's perforating. And if there's still something left inside the eye, it's an intraocular foreign body. So intraocular foreign bodies can actually be quite subtle. So they're not necessarily picked up immediately on examination. And this is an example of quite a small intraocular foreign body that's only really visible on CT scanning. What do we do initially for open globe injuries? Well, we give patients analgesic, as I said, and we give them antiemetics. Why do we do that? Well, patients who are in pain tend to squeeze their eyes, and eye injuries which are really painful can often make patients feel quite sick. And then when they vomit or retch, it increases the pressure in the chest and starts to squeeze ocular content out from inside the eye. So basic simple medications like analgesia and antiemetics are really important. And we also give patients antibiotics, and I'll come on to why in a minute. And then we cover the eye with a shield just to protect it. And then we do surgery to repair the eye. And it's essential that we do that quickly for two reasons. One is the risk of infection, which I'll come on to in a moment. Another is that there's a progressive reduction in vision and recovery of function with time left unrepaired. And so that's a cell death process, which again we'll come on to later. And this is what an injured eye might look like. This would be a very severe eye injury where the whole front of the eye has been injured. And this is what it might look like after initial repair at early stages. This is what we don't want it to look like. So this is a patient who's had an injured eye. You can see a suture poking out just at the top. But also, more upsettingly, you can see a layer of white cells just in the bottom of the anterior chamber. So this is called a hypopion. And so this is the area which the previous speaker, Rob Barry, would be quite familiar with. This is inflammation inside the eye. And in this case, it's caused by infection. So this is infection after an eye injury. And this carries a really poor prognosis. So an injured eye, which may be not very severely injured, which may be repairable with treatment. If it gets infection, that can cause loss of the eye and total loss of vision. So what can we do about infection? Well, we've known for some years that if you repair an eye more than about 24 hours after injury, you get an increase in the rate of infection. We know from more recent data, actually, it starts to increase a bit earlier, and more recent studies suggest after 12 hours, the risk of infection, also wound leak, increases. The risk is certainly higher with intraocular foreign bodies, but actually US military evidence from the war in Iraq suggested that you could leave intraocular foreign bodies in place for quite a long time. They left them in place for actually up to 3 months in some cases, after giving patients high doses systemic antibiotics as prophylaxis against infection. And that made us think, actually, potentially, could we avoid repairing the eye rapidly if we gave lots of antibiotics to reduce the risk of infection? And we initially thought that we could, and then later analysis showed that actually we couldn't. If we didn't repair the eye, giving systemic antibiotics might reduce the risk of infection, but if we didn't repair the eye within a day of injury, we still got a significant rate of infection. So what do we give as prophylaxis against intraocular infection? Well, we give antibiotics, and usually we give oral ciprofloxacin. In this country, in the States, they might give oral moxifloxacin. Why do we give ciprofloxacin? Well, one reason is the bioavailability after oral dosing is about the same as the bioavailability after intravenous dosing, so it's quite a convenient drug to give. The other reason is that it has quite good intraocular penetrations. This is a fairly old study where they dosed patients with oral ciprofloxacin. They measured serum and ocular concentrations at different times after injury by taking patients who were going to have cataract surgery and vitrectomy. So these are the serum concentrations. You can see most of them lying around the kind of 12 milligrams per litre mark, some a bit lower than 1. But in that kind of, around the 2 to 3 milligrams per litre mark, some of them a bit lower than 1, and fairly steady systemic levels of ciprofloxacin. And when they measure ciprofloxacin levels in the aqueous after cataract surgery, actually you can see those levels are quite comparable to the serum levels, between 0.1 and 1, but many of them close to 1. So they may be half, maybe a third of serum levels in the aqueous, which is actually pretty good. And the vitreous, we see similar levels to the aqueous. So ciprofloxacin after oral delivery actually penetrates the eye quite well. In contrast, an even older study of cefuroxime levels, which is typical of other drug bioavailability in the eye, shows that the level of ciprofloxacin in the aqueous humor is more like 5 or 10% of, or maybe even less of the levels in the serum. So in terms of drug delivery, we like to get antibiotics in the eye to prevent infection after trauma. And then, as Rob mentioned, antimicrobials. In the case he specifically gave foscarnet, but in the case of bacterial endophthalmitis, which is most common after trauma, we quite like to be able to get things that we apply topically into the eye. But ultimately, we can still deliver intravenously, but getting systemic drug intravitreally, getting systemic drugs into the eye is really quite valuable. The other thing we're worried about after eye injury is sympathetic ophthalmia. Again, this is in Rob's area. This is a uveitis. So a patient gets an injury to one eye, then weeks or even years later, they develop inflammation in the other eye, which is a granulomatous inflammation that can cause them to lose vision in their good remaining eye. And people used to think that if you remove the injured eye within 2 weeks of injury, you reduce the risk of sympathetic ophthalmia. But actually, there was a large study in South Africa published in 2008 where they looked at almost 1,400 cases of open globe injury, and they found that there was a very low risk of sympathetic ophthalmia if the eye was repaired or removed. But there was no particular indication for removing a severely injured eye, because actually, if the eyes were repaired, the risk of sympathetic ophthalmia was very low. But ultimately, this is again, there's no prophylactic treatment we give in terms of drugs. This is a treatment after the injury, after the condition has been developed, and the mainstay of treatment again is going to be steroids and immunosuppression. So if we could find a way of getting steroids to the back of the eye for treatment, that would be really valuable. So closed globe injuries. So these are injuries where there's not a hole in the eye. These are blunt eye injuries that I talked about earlier, and burns. The most severe of these is burns. Burn injuries are alkaline injuries, acid injuries, or thermal burns. These are a true ocular emergency. They're probably the most time critical of all the injuries we see. And alkaline injuries are most common because alkali is quite common in general life, particularly plasterers or cleaning products. And they're also the most serious injuries because alkali form soluble complexes with tissue proteins and continue to penetrate, so they can actually get inside the eye within minutes. And generally, injuries that the eye is red, these have a good prognosis. The reason is that around the edge of the cornea, so this is the cornea, and this is the sclera, around the edge of the cornea, there are stem cells that regenerate the corneal epithelium. So if the eye is red, then these stem cells are probably still intact. If the eye is white, these stem cells are probably not intact. So this is now with a poor prognosis that stem cells probably aren't there to allow regeneration of the corneal epithelium, and that eye then is likely to get scarring or even melting of the surface over time. And this sort of progression where there's failure of reepithelialization with progressive thinning of the cornea, conjunctiva and blood vessels growing over the surface, which would prevent a patient seeing, and then ultimately melting and perforation. So how do we treat chemical injuries or corneal burns? The first thing to do is to irrigate. So that's an emergency intervention. We irrigate with really whatever neutral fluid is to hand. That can be tap water if necessary. The quicker, the better. In a eye casualty department, they might get irrigated with saline or some sort of buffered salt solution. And then patients get given antibiotics, and they get given antibiotics because they're at risk of infection again. So this is another prophylaxis of infection after trauma. They get given mydriatics, which we can deliver very effectively just by topical eye drops, and they penetrate quite well. Those are drugs to make the pupil bigger, and that just makes the patient more comfortable, but also it stops the pupil sticking to the lens. And they get given pain relief, which we've talked about already. They get tetanus immunization, and then they get a variety of other treatments to help healing. And so that might include ascorbic acid, citric acid, which we give systemically on the surface of the eye. So more antibiotics and steroids. So one of the common steroids here will be topical dexamethasone. And then they get given systemic antibiotics like tetracycline, and that's used not as an antimicrobial, but as a matrix metalloproteinase inhibitor to try and help healing of the ocular surface. This is an example of the extent to which injury affects penetration. So we took some corneas and we injured them with acid injury or alkaline injury, and then we applied sodium fluorescein and rhodamine B. And so you can see the extent to which rhodamine B penetrates the eye, which is not very much. And fluorescein does penetrate the eye a little bit after topical application in intact cornea. Whereas after acid injury, you get this coagulated protein on the surface, and that actually forms a barrier to penetration. So you get fluorescein sticking to the surface of the corneal epithelium, but not really deeper into the eye. Whereas after alkaline injury, the epithelium is destroyed and the fluorescein penetration actually increases. So we can then measure that by measuring how much fluorescein and rhodamine get through the cornea after injury. And we find that after acid injury, both fluorescein and rhodamine penetration are reduced compared to the intact eye. Whereas fluorescein penetration, but not so much rhodamine penetration, is increased after alkaline injury. Why would fluorescein be increased and not rhodamine? Well, the epithelium has been removed, and that forms a barrier to the hydrophilic fluorescein, whereas actually it's the aqueous stroma that probably forms more of a barrier to the relatively lipophilic rhodamine. How does that affect a common drug we use? Well, dexamethasone is hydrophobic, and penetration is not greatly affected actually after alkaline injury or acid injury. But the amount of dexamethasone that gets into the or sticks to the cornea is actually increased after acid injury. So it's worth thinking about this in terms of we often look, as I showed you previously, at antibiotic penetration or other drug penetration after in normal physiology, but actually in the pathology we're dealing with, in the conditions we're dealing with, inflammations and injuries, that can affect the delivery of drugs. The other condition that can happen after ocular trauma that requires urgent intervention is hyphema, which where you get blood in the front of the eye. We can again see a fluid level or a kind of level of red cells collecting at the bottom of the anterior chamber. These can affect just a small portion of the eye. They can actually fill up the front of the eye. The more blood's in the front of the eye, the more likely you are to get increased intraocular pressure. The other thing that can happen when the eyes suffered a closed globe injury is you can get recession of the iridocorneal drainage angles. This is a picture that would be familiar to ophthalmologists, but probably not to anyone else, which is a way of looking inside the eye at the trabecular meshwork, which is where fluid drains out. And actually you can get stretching and scarring and breaks in that, which can lower or increase the intraocular pressure. And ultimately, all of these things can cause raised intraocular pressure after trauma. And we've got a talk later today by my colleague Imran Masood, who's a glaucoma specialist, who will spend quite a lot of detail on management of intraocular pressure, so I won't go into that. But that's a combination of systemic and topical medication again. The other thing that can happen when the eye is subject to a blunt injury is you get stretching, and that can pull on the vitreous, and it can pull on that. The vitreous is attached to the retina, so it can pull on the retina, and then you can get a tear in the retina that looks like this, and that can let fluid get under the retina, so you can get a retinol detachment. And a retinol detachment is when there's fluid gets underneath the retina and separates the neuroretina from the retinal pigment epithelium. Progression of that will eventually involve the whole of the retina, and that will cause loss of vision. In trauma, you can get tears at different parts of the retina, which have slightly different names, like retinal dialysis, but ultimately it can all cause loss of vision from fluid coming under the retina, separating the neuroretina from the retinal pigment epithelium, and ultimately taking it further away from its blood supply in the choriocapillaris, capillaris, so it becomes ischemic. This happens in about half of cases of trauma. So about 50% of trauma gets retinal detachment. And if you recall, we were talking about ciprofloxacin and other antibiotics and how they penetrate the injured eye. Well, this is a fluorescein angiogram. So this is a way of looking at the blood-eye barrier. So the extent to which the normal retinal circulation stops proteins, molecules, and therefore also drugs getting into the eye. And this is an injection of fluorescein into a vein taken a few seconds before this photo was taken, and the photo is filtered to show the fluorescent dye in the blood vessels at the back of the eye. As we can see the optic nerve, and we can see the nice outlined retinal arteries and retinal veins, which haven't got any leakage at all. So the dye is stuck in those blood vessels and isn't getting out. And the background fluorescence you can see is from the choriocapillaris. After retinal detachment, on the other hand, we get a slightly different picture, and we start to see leakage from these blood vessels. So we actually see areas where the dye is leaking out of the blood vessels, and that's normal after retinal detachment. So after retinal detachment, which I said happens in 50% of cases of ocular trauma, the blood-eye barrier is disrupted. So actually, logically, it would follow then that whatever drugs we give the patient systemically are going to get into the eye better, potentially, after ocular trauma than they do in normal physiology. But that hasn't been studied. So we don't really know how much a drug gets into the eye after ocular trauma. The other condition that we're worried about after ocular trauma is proliferative retinopathy. So after open globe injury, about 50% of cases get a retinal detachment, and and after closed globe injury, you can get retinol detachment too. And about 10% of cases of retinal detachment, even in the best hands, are just with normal injury. Normal retinal detachment after trauma a bit higher, and we'll go on to get a retinal scarring process called proliferative vitreous retinopathy. And this is intraocular scarring that can pull at the retina and ultimately lead to total vision loss. There have been a variety of different studies of how we can treat and prevent proliferative vitreous retinopathy. Apologies for the typo in the title there, TH at the end. Ultimately, one of the mainstays of treatment in these studies has been intraocular steroids. So again, we're in the situation of saying, wouldn't it be good if we could potentially deliver steroids to the eye in a more effective way, rather than having to inject if we get steroids to the back of the eye. The final condition I'm going to be talking about is traumatic optic neuropathy. So this is where injury to the eye or the brain causes injury to the optic nerve. And so what we can see here is some relatively pale optic nerves. They normally have a pinker color than that, as you may have seen in the previous photos. They're pale because the retinal ganglion cells have died. And on the right-hand side of your screen is a visual field, which is showing an area that the patient can see, and you can see their visual field is grossly constricted, so they can only see about the central 10 or 20 degrees of vision, and that's much lower than normal. We detect that by looking at pupil reflexes. So we shine a light into one eye and then the other eye and back again, and we see dilation in the case that there's an injury to the optic nerve. In the most severe optic nerve injuries, you can see something like this, which is an optic nerve avulsion, where the optic nerve has actually been torn off the back of the eye. And this is an unfortunate case of a gentleman who sustained a shotgun injury that caused an open globe injury on this side. And this eye that actually looks intact is his worst eye, because he's sustained an optic nerve avulsion on that side. So traumatic optic neuropathies can be the most severe of all injuries. I won't, well, at least I'll try not to steal any of Zubair's sandwiches for later, but we model traumatic optic neuropathy by crushing the optic nerve behind the eye. The traumatic optic neuropathy that we model and in real life is an injury, therefore, to the optic nerve. So all the retinal ganglion cell axons originating in the retina run through the optic nerve back into the optic chiasm and then to targets in the central nervous system. And damage to the optic nerve, either when we crush it in rats or other animals, or in a clinical setting, damages those axons. And after damage to those axons, you get progressive loss of retinal ganglion cells, which is complete by about 4 to 6 weeks. And there are a variety of different cell death pathways involved in causing that retinal ganglion cell death. But the main feature to take away from this is that we don't have an effective treatment for traumatic optic neuropathy. Steroids don't work in this condition, and they have been tried extensively. So here's really a strong need for neuroprotective therapy. We don't currently have a neuroprotective therapy in clinical practice, but there's a strong need, one, to develop that neuroprotective therapy, and two, to find a way to administer it. And part of the problem with administering therapies for traumatic optic neuropathy is ease of access. So these patients are often severely injured patients, and they often don't get to see an ophthalmologist very quickly after their trauma. So some proponents of steroid treatments would suggest that you need to administer steroids within hours of injury, but in practice we're not able to get to patients that quickly to administer that sort of invasive treatment. And the idea that we could deliver something intravitreally within hours of injury is probably not realistic. So if and when we do get a good neuroprotective treatment for traumatic optic neuropathy, for it to be effectively administered, it really probably needs to be administered topically, so it can be given without the need for an eye theatre or an ophthalmologist to administer. So I hope that's been helpful, interesting. Happy to take any questions.
Thanks, Richard. Yeah, that's very interesting. Thank you. Okay, any questions, especially from our ESRs? I'll open up to them first. Okay, I can't see any. Right, I'll kick off with one of mine then, Richard. So in terms of all the different barriers and all the different eye presentations you talked about, which one do you think is the toughest barrier to cross in terms of our topical medications?
I think you've got two problems with delivering topical medications. One is that the surface of the eye is quite resistant to getting topical medications inside it. And the other is then the dilution and clearance problem. So we focus on getting medication through the cornea or through the sclera pars plana, and that's obviously the main barrier, just getting something inside the eye. But then in terms of getting something at an effective dose to the back of the eye, you've got to contend with the fact that if it goes through the sclera, for most of the sclera, it goes through the choroid capillaris and then gets cleared by blood flow, or if you deliver medication through the cornea and it gets into the aqueous is turning over all the time, so it gets cleared. So you need something then that can get in the eye, but also either essentially sticks around or distributes very fast, and that's where some of the slow release implants come in. Thanks. Back to you, Zubair.
Okay, if our ESRs are shy, you are welcome to use the chat just to type a question. One other one I'm just going to hog this, as the chair always does usually in these meetings that I've been to. You talked about the timing then. So whatever treatment we develop, that might be an issue if you can't get it to the patient quick enough. Especially do some of the caspase treatments that we're thinking about, and I'll talk a little bit about it in my presentation. But how can we improve that?
Yeah, part of it is diagnosis. So as neuro-ophthalmologists, we often don't make a diagnosis very fast. Part of it is just the level of engagement of ophthalmologists, say with trauma services or other clinicians. Part of it is patient presentation. But ultimately, it probably also comes down to the level of risk of treatment that you're giving and the difficulty of giving that treatment. So one treatment that has previously been mooted, which doesn't work either for traumatic optic neuropathy, is optic nerve decompression. It's a surgical treatment. You need to go to an operating theatre, you need a specialist surgeon. It's quite high risk. It's quite difficult. So the chance of getting that quickly is low. Same for steroids. Actually, in steroids and traumatic optic neuropathy, they're quite high dose steroids. They carry risk. And so you certainly wouldn't want to give them to everybody. And actually, in truth, you don't want to give them to everybody because, again, they don't work. But if you want a treatment to be given quickly, it needs to be easy to give and it needs to be low risk. So if you've got a treatment that's easy to give and low risk, and anybody can give it with a low threshold. Whereas the higher the risk of treatment, the more you've got your junior doctor at 1 o'clock in the morning kind of sucking their teeth and going, oh, I'm not sure if I want to do this, or I'm not sure if I don't. And so in the case of the caspase 2 therapy that you mentioned, where there have been clinical trials, the treatment itself is relatively low risk, except that it's delivered by intravitreal injection.
Yeah.
And so if you had something that you can just randomize a patient onto an eye drop, then they might have been able to recruit a bit faster than 2 weeks, which is ultimately where they ended up recruiting.
Thanks, Richard. Thanks, Richard. Okay, in the interest of time, I'm going to stop you there, Richard. Thank you very much for that. Okay.